Intestinal ischemia. Etiology, pathophysiology, and pathology. As with vascular disease elsewhere in the body, the gut is prone to ischemia from either progressive atheromatous narrowing of the mesenteric arteries or thromboembolism from intracardiac or proximal vascular sources. Epidemiology. Vascular disease in general is increasing in most developed countries. Risk factors include age, male sex, family history, smoking, diabetes, hypertension, hyperlipidemia and atrial fibrillation. Clinical presentation. Common. Ischemic colitis. Bloody diarrhea, usually of sudden onset and associated with abdominal pain. NB. Ischemia frequently affects the splenic flexure of the colon, which is the watershed between areas supplied by the superior and inferior mesenteric arteries. The cecum and distal terminal ileum are also commonly involved. Small bowel infarction. This is usually due to arterial embolism and presents as an acute abdomen, often with severe systemic disturbance, hypotension, acidosis. Uncommon. Mesenteric angina, recurrent postprandial abdominal pain and weight loss. Physical signs. Other features of atheroma, arcus, xanthelasma. Potential sources of arterial embolism, atrial fibrillation, heart valve disease. Abdominal brutes and other evidence of vascular disease. Investigation. Radiological. Plain abdominal radiograph may show aortic calcification and colonic mucosal edema, often with thumb printing, which may be of relatively limited distribution compared with other forms of colitis, e.g. distal transverse colon and splenic flexure. CT or MRI angiography, the presence of significant stenosis or occlusion of 2 out of 3, celiac axis, superior mesenteric artery and inferior mesenteric artery, vessels is suggestive of significant disease. The superior mesenteric artery needs to be involved to justify intervention. Mesenteric angiography confirms the radiological diagnosis and may allow therapeutic intervention to be performed, e.g. angioplasty or stenting. Other. Colonoscopy may reveal ischemic changes but carries increased risk of perforation in this context and is not recommended if ischemic colitis is the most likely diagnosis. Differential diagnosis. This includes colorectal carcinoma, diverticular change, inflammatory bowel disease, peptic ulcer disease and chronic pancreatitis. Treatment. Acute intestinal infarction often requires emergency surgery for bowel resection. Lesser degrees of ischemia, e.g. ischemic colitis, are usually managed conservatively. Complications. Intestinal strictures and obstruction. Prognosis. Excess mortality is associated with other features of vascular disease, ischemic heart disease, stroke, renal failure, etc. Acute intestinal infarction carries a high mortality rate and significant long-term morbidity, often requiring parenteral nutrition.